Hi, Stephanie. Hi, everyone. It's great to see everyone and have a chance to meet you. And I hope you've had a fun weekend so far. My name is Jennifer Dent. I am the president of BioVentures for Global Health, a nonprofit organization based in Seattle, Washington, that works at the kind of crossroads between the private sector and global health initiatives or global health organizations. I participated, and members of our team participated in the COVID-19 hackathon, taking on COVID-19 in Africa, which was a fantastic event a few weeks ago. And my background before working in the nonprofit sector was working in the private sector with Genentech early on, and then Roche, and then Genentech again in life cycle product management and business development and alliance management. So I'm looking forward to hearing the pitches, and I'm sure there's a lot of great ideas that we'll learn about today.
Thank you. Stas, how about you?
Hi, I'm Stas. I'm currently working at the Chan Zuckerberg Initiative in their venture investing group, where we focus on education globally as well as healthcare. Healthcare is actually a newer area of focus for us that I was brought on to kind of help spearhead. Prior to working here, I spent some time in digital health investing for the American Medical Association, and I actually spent most of my career in private equity. But I'm much happier to be working on much more philanthropic things as of now, and also I'm really looking forward to hearing everyone's pitches.
Awesome, thanks. Zach, how about you?
Hi, everybody. Like all the other judges, happy to be here. So I lead U.S. healthcare partnerships for Plug and Play Health. Plug and Play is primarily a venture capital firm. We've made a little bit more than 1,300 investments in the last 10 years. We were fortunate enough to be early investors in Dropbox, PayPal, and about 9 other unicorns. On the healthcare side, we've made about 60 investments now. And also, not only that, but also have launched with our leadership team our COVID-19 accelerator as well. But was really impressed by all the teams last time. They did a fantastic job, and I understand this track is everybody who did the best job from all those tracks. So really looking forward to hearing about not only some of the ideas and teams I didn't get to see last time, but also some of the progress that's been made since then.
Excellent. And then Vivian, I believe you're here as well, if you'd like to introduce yourself quickly.
Sure. Hi, Vivian Lee. I'm the president of health platforms at Verily, which is Alphabet's healthcare and life sciences company. Been there for 2 years. I'm a physician by training, MR radiologist. And before that was in academic medicine my whole life, leading healthcare systems as a CEO. And I actually have been an HST alum. So actually spent a lot of time on the MIT campus. So anyway, great to be part of this. Thanks for having me.
Excellent, thank you. All right, so just as a reminder, we are recording this session. So welcome to Beat the Pandemic 2. So this is our 5th event. I was kind of starting to explain this earlier, but this is our 5th event. So we've done ideathons, datathons, buildathons. We've done an Africa focus challenge, and this is kind of the second iteration of our big Beat the Pandemic 1 challenge, where we have all of these incredible clinical partners, all of these incredible partners just across the board that have helped us bring this to life, that have helped fund the money that the startups are going to get who win. In this track, we're going to be picking 3 winners, and each of them will get $5,000. So we're in our final presentations. You guys have been working so hard all weekend. We got to see you from the very beginning, where returning teams, everyone in this track is a returning team. And so you guys came with a few of your members from your previous hackathon, folks that you guys have brought on since then, and supplemented your team with some incredible newcomers. And over the course of the weekend, you have started out with an idea that was already pretty solid. And so what's going to be really fun for us is seeing what you were able to do this weekend and what you've done since the first iteration of the Beat the Pandemic Challenge. We've already met our incredible judges. So just as a reminder, this is who those folks are. I'm sure you're going to want to remember them, reach out to them. They're going to give you a ton of amazing advice. We are going to be pitching for 3 minutes, and the judges are going to get to do Q&A for 2 minutes total. So it's pretty rapid fire, but to get through everybody in this time frame, we kind of have to be pretty rapid fire. So these teams have done a ton of work to shorten and compress and boil down their ideas to 3 minutes, which is so hard. And so they've been very strategic about what they're going to be sharing with you, and what they hopefully will encourage you to ask during Q&A. And even that's a very short time. So it's going to be very, very fun to see how this goes. Like I mentioned, we started this on Friday evening, where we were all in one big Zoom room with the 2 returning teams, and all of the returning teams were able to pitch their ideas and what they were looking for, whether they were looking for developers or if they were looking for some other specific talent. Over 150 newcomers to the new participants also joined those rooms and were able to find teams that they were interested in working with. So then all day Saturday, these teams built new things, and it was really wild because we were able to do little pulse checks where we dropped into the rooms to see how they were doing, how the teams were getting along, what they were working on, what they needed help with. Later in the day on Saturday, we did practice pitches. So some of the mentors that were involved with those practice pitches are actually on this call, and they're so excited to see your progress. And then on all night, these teams were iterating on that feedback, and the progress I was able to see just from, Friday night or Saturday night to Sunday morning was incredible. So we saw some of the same teams at 9 p.m. and then again at 8 a.m. and they had implemented all of the feedback. It was incredible to see. And now here we are. So I can't wait to see it. So the judging criteria for this track are the 5 things we've mentioned before. It's impact, innovation, implementation, presentation, and also the key for this track that's very different than the newcomer tracks is what progress have you not only since last Beat the Pandemic, but also this weekend. So we've kind of gone through all of this. The presentations are all being recorded. You're welcome to have multiple members present, though it might be a little tough in 3 minutes, but you are welcome to do that. You have 3 minutes to present, 2 minutes for Q&A. We have to hard stop you. I've been warning you about this for days, and I hate to do it, but we have to hard stop at 3 minutes to be fair to everybody. We've already posted the order of the teams. Ignacio is going to be chatting with you and just making sure you remember who's up next, but we're also going to be flashing the up next when each team starts. Raise your hand. We've talked about this, so just unmute yourself if you're the presenter. When it's your turn to present, just like unmute yourself, and then I'm going to be flipping your slides for you. So give me a little cue, give me a little next, or click that video, or whatever the case may be. Just do what I'm told. And then I have these handy dandy things. This is going to be your 1 minute warning, and this is going to be your 10-second warning. So like wrap it up ASAP because I'm about to cut you off. It's sparkly. I don't know. I think it's orange. I meant for it to be red. But so try to keep me, if you can, in your view while you're presenting so that you can see when I'm doing this for you. Finally, I mentioned before, we're going to be picking 3 winners, and they're each going to get $5,000. So once again, just unmute yourself, and then you get 3 minutes. Okay, any final questions before we get started? I see a couple folks in the chat. Vivian, I'm not sure. I think you're muted if you were speaking.
No, I'm fine. I'm good.
Okay, cool. All right, cool. So is Cove Connect ready to go?
Yep.
All right, let me share my screen. Do you guys all see my screen and you see it?
Yes.
Sorry. Wrong button. I see one more thing in the chat. And after this, I will be ignoring the chat, and Ignacio will be manning the chat. So message him if you need anything. All right, everybody sees my full-size screen. Excellent. Go ahead, Anatoly.
My name is Anatoly, and I'm a legal tech entrepreneur. You can click the next. I was terrified when I heard stories when COVID-affected families lost their close ones without having an opportunity to even say goodbye. which made me pick the isolation track during the first hackathon. Next. Did you know that 28% or 139 million people of community-dwelling Americans are 65 years and older, live alone, or report feeling socially isolated? On the chart, on the top 3 groups affected by COVID-19 are 65 plus. 11% of all US deaths occur in nursing homes. COVID-19 related deaths in nursing homes account for 1/3 of the country's pandemic fatalities. Older, lonely, and isolated people have weakened immunities to fight off viruses such as COVID-19. Next. That's why we've developed COVID Connect, to reduce the feelings of isolation through a web-based platform connecting patients worldwide with their social networks when they need it the most. It has high impact and is super feasible as it works with existing hospital infrastructure and COVID-19 policies. Next. Our web app allows families to send encouraging notes to their loved ones and connect with their families that are affected. Since the first hackathon weekend, we were able to gather a lot of developers who contributed to the project. We're so excited to announce that our demo we showed you right now is ready for beta testing. Next. The innovation is in the process. We have a novel workflow where existing hospital facilities are utilized and can be easily adapted through printing family-sent messages and attaching a warm note with a warm meal. Next. For the second hackathon, we had a goal to further validate our app and develop a strategy beyond COVID-19. Next. Our concept has been validated by a team of experts from the medical and mental health industry that was validated on the first hackathon, next, and on the second. To summarize, the feedback was the following. We see value in the solution like this, and we would like to chat with you next week and next month to see how we could connect with you, right people, and give it a test run. We plan to roll out the app in the next month in US and Brazil and further learn and scale the solution. Next. Our app would be supported by hospitals as they want to reduce burden for their doctors, and we have opportunities for paid advertisement and government support. Next. As a result of our first hackathon, we believe, the second hackathon, we believe that our solution might be useful for post-COVID as well, as we can bridge the gap between volunteers who could spread care and love and those lonely patients in hospitals and nursing homes, with only with a warm message and a set of intelligent tools. Next, please. In our 3-step tech approach, we'd go from paper and tape to smart devices like speakers, cameras, and screens, to even more complex integrations with AR solutions and data bridges with existing EHR platforms. Next. We have amassed an amazing team during the 2 hackathons and the time between them. Moreover, next, we've added 2 new members at this hackathon, a team with truly diverse backgrounds. Next. We're providing a highly impactful and feasible solution to improve the mental health and well-being of vulnerable COVID-19 patients and bridge the isolation gap post-COVID. So, are you ready to connect with us on COVID Connect? Thank you.
Thank you. Amazing job. I will now turn it over to our judges who, in any order you like, can unmute yourselves and ask any questions.
Hi, Zach Pohl. I can go first. So to be clear, what's going to happen is from you to implement, you have to reach out to the hospitals, get them to say yes, if they're going to put the messages on the receipt that gets to them. And they need to figure out internally how that's going to happen. And then you're going to be charging the hospital for that.
As this is covered by MIT's open source non-for-profit license, we wouldn't be charging anyone to start with. We want to accumulate use cases and see how it works. We've already reached out to hospitals and get their interest in testing this out. And the next step for us would be to help them with the workflow to manage the fastest and the easiest way to implement this, not necessarily on the receipt. It could be also printed on just like regular paper and printer, or it could be attached not only to a meal tray, but with blood samples in the morning or when there's a contact with the COVID patient. So we'll help them with the workflow. We have some people interested and on board, and it's just for us to connect the dots.
Okay.
Could you explain a little bit more about the meal connection and how that actually would work?
Yes. So through our platform, the family could easily send a message to the patient. We have a separate login for the medical staff. They would log in, see that the message was received, print it out, fold it, and then hand it over to the kitchen staff or tape it to the meal tray themselves. And when it's time for food, the nurse would bring in the meal tray with the meal and with the note.
Thank you.
All right, we have 10 more seconds for judge questions, if you have any others.
Just one quick one. I'm a little confused on what's the monetization strategy.
So we are looking to integrate paid advertisement if we would need to monetize this. Also, we're looking to charge hospitals on a later stage for the usage of it. Alternatively, we could also have some grants, and because it's a low-cost solution, it doesn't need a lot of maintenance.
So, and do you know how families are communicating with patients now? I mean, how does this compete with other mechanisms to communicate, whether it's FaceTime or just instant messaging?
Totally. A lot of, like there are a lot of cases when people forget their phones, chargers, or elderly are not very tech savvy and can't use their phones. So for those who can establish a connection through a mobile phone or a computer, that's fine. They would manage it on their own. For those who are not able and are really isolated, moreover, for those who don't have a family, or the family is located in another city and they don't have time to call, we would encourage hospitals to let families know and supporters that there's a solution like this, so they could bridge the gap between those.
Okay, we're gonna have to wrap up the feedback and the Q&A, and I encourage the judges, you do have your judging form, to try and get those in after every team while it's fresh, so you can be filling them out while a team is going, and then during the Q&A as well, and then try to submit those as we go. So thank you, and now we're gonna be moving to team distance domestic violence. Go ahead and unmute yourself, whoever will be presenting.
Hi, can you hear me on the other end?
Yes, I can.
Okay, great. You can go on to the next slide.
Thank you, go ahead.
So our team is Distance Domestic Violence, and we're introducing our product, Steps Forward. Next slide. Our problem from Hack 1 is that every year it's estimated that 10 million people experience abuse from a partner or family member in the United States. But with COVID-19 and the stay-at-home orders, the conditions for domestic violence to occur have been worsened. Even before the pandemic, disclosing one's experience of violence and getting connected to the right supports was never a smooth process. Next slide. Our solution, Steps Forward, is a one-stop shop website that will take users through the journey of disclosure and connection to service providers via a screening tool. Next slide. Since the first hack, we focused our efforts on research and refining our concept. We've completed 8 interviews with service providers and advocacy groups and plan to bring prototypes back to these users for testing with key stakeholders and survivors. Next slide. With the addition of 2 new members in Hack 2, we've utilized their skill set to focus on creating a welcoming and safe UX design and developing a database management strategy for our tool. Next slide. And this is our second prototype. It features a mobile responsive homepage and discrete design features to protect the safety of our users. We have intentionally designed the site with a large amount of white space to make it more difficult for an abuser to look over and see the content on the screen. We also plan to use features such as mode switch in order to pull up a neutral cover website that could be turned on and off at the user's request. Next slide. Our screening assessment includes a progress bar at the top of the page that users can follow as they're asked questions one at a time. Next slide. And for those who go through the screening, they will receive a prioritized list of service providers in their area based on the needs they indicated in their screening assessment. For example, if they identify needing a safe place to stay or preferring Spanish-speaking supports, those resources are curated up on the page. For those who don't want to go through screening, they can go to the general resource map and sort of self-serve by clicking through a menu of filters. Next slide. And we have also mapped out an initial data strategy. We plan to build a HIPAA-compliant RDS database using AWS infrastructure. To achieve our goals, we need to build a database with multi-sector service providers with defining key characteristics in this data structure, such as language supports that they provide, whether they have childcare services on site, and so on. We plan to use some web scraping to help us obtain this information. Currently, there is no large data set specifically for the domestic violence sector because it's so multi-sectorial, but we expect that there will be some manual scraping required. So moving forward, we plan to keep on researching. And if you go to the next slide, you'll see a full list of our team. Thanks so much for the opportunity.
Great job. We'll kick it right over to the mentors for 2 minutes. For the judges, sorry, for 2 minutes. Judges, feel free to unmute and ask any Q&A.
I guess I'll start. I think Vivian asked a great question last time that applies here is how are people currently solving these challenges if they are stuck in this situation?
Yeah, so currently the system navigation in the domestic violence sector, there really isn't one. And there really isn't a sort of emerging evidence base around where the right place to go is. Often we hear from healthcare providers that it takes 3 years for someone who's being screened at a healthcare site to even disclose that they're experiencing this and get connected to the right supports. Almost 50 incidents occur between that time. So we really want to create a safe place for someone to disclose. Often the disclosure that people take, it might be with friends or with family members or with a healthcare provider, and that disclosure might not seem safe. So in terms of the IPV journey, it's often a sort of back and forth process. By creating a safe space online that a user can kind of revisit and sort of get curated supports, because there's a plethora of information online that might not be specific to the situation that they're facing because there are different types of abuse, our screening tool helps filter that out and sort of connect them to that right supports, encouraging them to sort of take those steps forward in a sort of very clear, actionable way. And it's sort of journey mapping for them in a more sort of precise fashion.
Cool, 30 more seconds of questions.
Well, I think that, oh, go ahead.
I was just going to say, have you thought about who you would want to partner with to actually implement this solution?
Right. So right now, like a lot of the hotlines do the referral to community service providers in their area, but quite, in terms of what they do, their action is mostly a hotline. They're on the phone. Chat services and online functions are just emerging, and we think that this is a feature that they could host within their platform. And we want to work on building out the MVP and sort of user testing it in order to sort of bring it to those sort of referral points that are not utilizing the digital space currently.
Awesome, that's all the time we have. Thank you, Arani, and great job. Next up, we have Project X. I'll give the judges a moment to populate the judging spreadsheet with the next team's information. And who will be presenting for Project X?
I will.
Awesome, cool, and I hear you. So go ahead, ready when you are.
Okay. I'm Teddy Thomas with Project X. We're here today to present a new app, Stop. Stop offers hope to those feeling hopeless. Next. Ellen is a hardworking 43-year-old single parent of 3 children working in the hospitality industry. She's been laid off and is struggling to find the support she needs through these trying times. Next. During the COVID-19 pandemic, the call for community support is in greater demand. This time of crisis has left many people feeling desperate, overwhelmed, and hopeless. The numbers are staggering and have created the perfect storm. Next. When one is in crisis, everyone is in crisis, creating a ripple effect. Next. Through 4 steps, we walk with the user to assess their current feelings and build a community around them. Next. We will build a digital phenotyping service through testing verified data, listening to the feedback of trusted sources, and creating a safe space for our users. Next. We build this safe space through our double-layered support network. Our users are supported by their community, and their community will be supported through pre-existing suicide prevention organization. The accountability loop ensures actions to be integrated at all layers. Next. Building the secure and private interaction using Salesforce and AWS will make it applicable to more communities and a trusted resource. Next. Our solution provides a one-stop shop for the prevention of suicide, creating patient-centric care and resources for those in need. Next. An analysis of similar apps shows that STOP can provide greater resources, including options such as voice activation, geolocation, support group engagement via call, SMS, email, machine learning, Internet of Things, and artificial intelligence. Next. Based on the market research, communications with professional industry, urgency of support needed in these dire times, we transitioned from Be Happy, an app platform, to STOP, which saves lives. We have added additional team members and also started a basic prototype of the concept. Next. Funding would provide a dedicated support structure, including design, development, analytics at all levels. STOP, a suicide prevention app that has immediate crisis response with voice activation. Not will only change the destiny of one person, but the lives of everyone around us in today's crisis and COVID-19 pandemic and beyond. We believe STOP will provide the hope that we have for Ellen in their darkest moments. Thank you for my team and the mentors for their time and dedication.
Awesome. We'll push it over to the judges for Q&A.
Are you thinking that this would be distributed direct to consumer through the App Store, or as a recommendation from a physician or a nurse practitioner?
Sure. So the first layer specific to the crisis response would go through direct to consumer via the App Store. And then from there, there'd be other phases where we would have the application to employers, folks within the military, to build out the other additional functionalities.
Could you say a little more about the voice activation?
Sure. Yeah, so the idea is that when someone is in a state of crisis, they might not have their phone around, but they might have Google Voice, Alexa, or Siri. And so within that prompt, an individual can have a safe command that triggers that activation to engage within their trusted network to have an action step that closes a loop of what that person has already predetermined as their crisis response. So usually when somebody is disabled or can't get to their phone, the only thing they can ask for or say is through their voice. And so if there's certain devices in their house that could pick up that individual's voice, would trigger a call response or a text response.
And how are you going to link this with Alexa or some of those platforms?
Sure. So right now, what we have is a prototype, but once we have the proper funding to have an AWS developer to build out the solution, we can integrate it as a skill that Alexa would have specific to a suicide prevention hierarchy using the trigger response that we've predetermined.
And that is all the time that we have for Q&A. Thank you. That was amazing.
Thank you.
All right, next team up is Viral Science. Who's going to be representing Viral Science?
Hi there, me, Alina Bengert Lombardi.
Awesome. All right, we can hear you and feel free to get started.
Talk about background. Okay, do I say next, I guess, to start with? Next? Oh, never mind. Sorry, I thought this was going to give us introduction. I apologize. Okay, we're Viral Science. We present credible information worth spreading. Next. In today's world, information spreads so quickly and false or misleading information can go viral in seconds. During this pandemic, the shared information is somewhere across the spectrum of fake news to boring, scientific, and complex data, overwhelming us. So how do you find the truth in a noisy world? Next. The challenge we face today is that people are struggling with information overload and flooded with conflicting information, not knowing where to believe, whom to believe. People seek clarity. During this pandemic, our survival depends on reliable information. And based on user research we conducted this weekend, majority of users believe that misinformation is a very serious problem. Next. The truth is not always 100% black and white. There are uncertainties and ongoing research. What is true today may not be true tomorrow. Influencers and social media communicate misguided information when reliable information needs to be conveyed in a timely manner. As you can see in February, there were conflicting ideas about masks. By the time importance of masks was conveyed in April, the spread of virus increased. There's no central location for reliable COVID-19 information. Next. That's where we come in. Viral Science provides a central hub with information that is impartial, credible, and easy to understand. Next. Viral Science is mobile friendly and easy to use with features such as curated content specific to you, daily meters, and helpful resources. All the information is easy to understand, timely, and verified, validated by a team of experts. With one touch, you can share content across your social media platforms. Viral Science is one-stop shop for all your COVID-19 related information. Next. Let me tell you about our process. Information is first gathered through original content submission and web scraping software, such as Juicer or Dent. Then it is reviewed and validated by a team of experts. The information appears on Viral Science where it can be shared across social media platforms. Next. Since the first hackathon, we made progress. In addition to growing our team, we had ideated on the solution, created mobile prototype, and conducted user research. The next steps for us are to build mobile sites, seek partnership with credible independent partners, and seek technology support. In the future, our platform can be used for any viral information, not just COVID-19. Next, meet our team. We have an enthusiastic team of talented members with varied backgrounds. Next. Remember, we provide you with bite-sized credible information that allows you to go viral. Thank you.
Awesome. I will send it over to the judges to unmute and ask questions.
Can you talk a little bit, this is a great presentation, can you talk a little bit about the how you expect to determine who the scientific experts are, or who's going to determine whether this is credible, and how are you going to make that the volume of work for them feasible?
This is an excellent question. We have some solutions in place that we're discussing. Some ideas have been around, well, first of all, one of our team members who is actually, one of our team members is an MD PhD who has resources and contacts who can be a part of this team. They already shared interest. And so we can have, but of course we want to scale it. But we're thinking about percentages and numbers. So having, you know, let's say 90% of scientists believe this to be credible or something like that, that kind of number to be shown on the articles. And also another idea was to consider having, so to consider having a certain criteria that we provide for them to help determine whether it's credible, and it would be impartial, and it would be something that could be used across different types of information. And I'd like to invite Martina to just, if you have anything to add, she said she would help me with questions.
Yes, so I think I agree with everything you said. I would just add that we want to value quality over quantity. So
Correct.
basically the board of experts would be handpicked, and then there would be needed approval by multiple members from this board, from their area of expertise, for the stuff to be pushed online. Does this answer your question?
Would you see any kind of a role with the CDC, or have you thought of how you would work with organizations like the CDC, the World Health Organization?
That's a very good question. You know, we've been thinking about partnering that would be need to be very independent because we plan on being impartial and politically neutral. That's one of our top priorities. So when it comes to partnership, we were actually thinking that it would be excellent to have a university as a partner. Maybe some university that already is involved in COVID-19 and maybe it already has activities around meters or other related information to COVID-19.
Thank you, Martina. We're gonna have to cut it off there, but great job, you guys.
Thank you.
All right, who is representing Cody?
With your pitch for you to be the university for them, by the way.
I got that. Maybe like MIT. Okay, who's got from Cody? Who's going to be presenting?
I will.
Excellent. All right, take it away.
Okay, next slide. So I will start with a question for the judges, actually. Have any of you had a test for COVID-19? So some people have. If you have, you're in a very small minority. I am actually one of those as well. I went in on Friday, had a test, had my blood taken, swab stuck up, up my nose. It wasn't actually that bad though. What I was more surprised by was the fact that there are about 15 or 20 nurses waiting around and just 2 of us there who were being tested at the time. So it seemed like a bit of a waste of resources. At the same time, if you look at the right-hand side of the screen here, this is one patient on the same day with 2 different results from different antibody tests. So you don't really want to trust those either. Next slide. Our mission is to make those types of decentralized diagnostics accurate, affordable, and easy to use. So what we will do is calculate an individual's likelihood of having had COVID-19 in the past, having some immunity right now, and of catching COVID-19 in the future. Next slide. I'll take you through a typical user experience. So Mary is online one day and she sees a link for at-home testing for COVID-19. She had a cough and a fever back in April, so being intrigued, she clicks on the link where she's shown verified and affordable antibody tests, and she decides to order one of them. When it arrives, she fills out a questionnaire, watches some video instructions, applies a pinprick drop of blood to the test, and 10 minutes later, takes a photo of the test and has an answer. She did have COVID-19, but is now recovered. Next. Cody works by taking that final image of the test and classifying it according to our highly trained and fine-tuned ResNet 50 CNN. Next slide. But that's just one of the inputs. So we work with a Bayesian framework that takes regional prevalence data and uses specific data provided by the questionnaire. And together these are combined to provide a much more accurate posterior probability distribution. Next. So does it actually work? Well, you can see that no matter how good the tests are, our algorithm will always improve on the diagnostic accuracy. Essentially, using real patient data, we found that we can cut the false positives and negatives by about 50%. Next. So others have recognized the value in this project, and Lumiata awarded us first prize in their hackathon, and AWS DDI provided us 10,000 in credits. And CovClear, who provided us with the patient data in the first place to train the model, are looking to form a nonprofit with us to provide this app as a service for various industries. Next. So in summary, since round 1, our team has grown. We've established collaborations and obtained key data sets, and our core algorithms are working well, but we still need to complete our front end and user interface, raise awareness of this app, and look for further collaborators and support. Next. We expect to have our MVP ready in 2 weeks, and although it was just a couple of us this weekend, next. There are actually many of us that I need to thank, as well as all of you for your attention. So thank you.
Awesome, thank you. Judges for Q&A.
I'm going to bring up one that's actually pretty relevant to the judges. I got my COVID test done through Verily, and it was fantastic. Thank you, Vivian. Very easy. But can you talk about kind of what are the benefits and value here that you wouldn't be getting through one of the other ways to figure out if you should be getting a test like how Verily provides?
So figuring out how you can get a test is essentially what our questionnaire already does reasonably well. It gives people that likelihood, a prior probability distribution that we then feed in once you do get the results to provide an even more accurate result. I actually haven't seen exactly how the Verily system works, but the other competitors we know provide their own antibody tests, and they're somewhat limited in how much they can grow as a result of that. But relative to the other testing centers, the idea is that at least now for your healthcare workers, you can actually get a test sent to you and do it by yourself in a pretty short time.
Are you mostly talking about an antibody test, not the actual virus, or not the antigen, right?
Right now, only the antibody tests have reached the sensitivity and specificity requirements that we would deem acceptable. Antigen lateral flow tests are in development, and that's where we're looking to move towards.
And are you primarily focused on trying to reduce the unnecessary testing or help groups of people manage their population? What's your primary goal?
Increase the amount of testing, particularly when antigen tests become available for people to do repeated testing, whether it's for, let's say, dentistries who want to be able to say that their dentists have been approved free of the disease that day or that week, or we've had interests from actually military groups and from the music industry as well, who want to basically roll out more frequent, accurate, decentralized types of tests like antigen lateral flow tests.
Thanks.
Thank you. That is all the time we have. That's our 2 minutes. That was awesome. I really appreciate it.
Thanks.
All right, next up is Covis. Who is representing Covis?
Oh, we have two of us. It's myself and Jeff.
Hi, can you hear me okay?
Yes, I can hear both of you. All right, I will mute myself and start your 3-minute timer.
Great, we can go right to the first slide here. Hi everyone, we're Covis. Our data-driven platform solves the problem of helping individuals and organizations balance risk and understand how to stay safe in the ongoing COVID-infected normal. So on this slide, you can see exactly what we mean by that. So individuals are struggling to understand whether they can and should return to work or to their loved ones. Healthcare providers, payers, governments, businesses are all in the same boat. So on this slide, I'll introduce you to our solution. It is a personalized dashboard. If we can go to the next slide here, that's given us the user forecast, a COVID risk evaluation, an explanation of how we got these estimates, and then steps a user can take to improve their COVID safety. To derive all this, we use user input location history and personal information combined with big data and machine learning. The user is then empowered to understand what their personal attributes and location mean in terms of COVID risk, and they can act accordingly. On the next slide, there are other incumbents in this space, but we think Covis has a few notable differentiators. One, we're using location data versus Bluetooth. Bluetooth requires a very high user adoption rate to get to useful information, whereas we can parse location data for risk factors standalone. Second, we put privacy first and have transparent practices and policies. And third, we think we have more sophisticated algorithms allowing superior output. On the next slide, you can see our talented international team. We have expertise in modeling, machine learning, public health, tech, user experience, and the healthcare business. We also have a great set of affiliations, and we've managed to accomplish a lot. On the next slide, John will take us through that.
Thank you, Jeff. Since the last hackathon, our team has been working incredibly hard to bring together the pieces that will define our foundation moving forward. To do this, we have been working with AWS and DESI to solidify funding opportunities, building out and testing our algorithm, starting our AWS infrastructure, and reaching out to possible users to get their feedback on our design and approach. On the next slide, you will see the awesome new additions to our team this weekend. As a continuing team in the hackathon, we have gained 4 new incredible teammates. These guys have the skill sets and backgrounds that we have been needing in order to close the technical gaps, previously putting our MVP launch date at risk. On the next slide, you'll see just how much these guys have helped us build out in such a short period of time. This weekend, we focused our work in 3 parallel work streams with a goal to burn down as much technical risk as possible toward taking our platform live. Our AWS infrastructure went from just a couple database instances to a serverless platform architecture with defined database schemas, multiple databases created with version control, our API gateway, and many other items. Our interface to our backend went from non-existent to a reachable endpoint with automated scripts built in, and our application front end went from designs and an online visualization tool to an application that we can now launch on our phones and interact with. On the next slide, you can see where we're at in our platform development timeline. As mentioned, coming into the weekend, we had made significant progress toward our MVP, but still had a lot of gaps to close in the foundation of the platform itself. With our new teammates and the work that we have done, we are very well positioned to build our entire product in the given timeline shown. On the next slide, we'd just like to say a special thank you for this incredible opportunity to all the team leads and track leads. And if you guys have any questions or want to follow us, please see the links on the slide. Thank you.
Great job, guys. We'll kick it over to the 2 minutes of judge Q&A.
What's your business model that you're thinking about, please?
So I'll take over that question over here. So basically we have a short-term and long-term business plan. Our main thing was that we needed our MVP launch, which we were able to secure by securing some new members this time around. And also basically first we need to implement our MVP, then we want a full launch solution and scale through with partnerships, potentially with hospitals, healthcare businesses, government institutions, and insurance companies, as well as having the individual user use this. But in terms of making a monetary profit from something, that's where we would have an option for businesses and insurance companies to have a dashboard in order to accompany their large companies. So we would be able to have an individual user base where an individual user can just use the platform and understand their risk to COVID and their immunity, and then also relate this to a larger and more broader scale of companies where this would be our business plan. And lastly, our main goal is to scale and enhance this to launch a hub for developers across markets internationally. Daisy, as one of our partners, is currently in Germany, and we have a lot of members in the US as well, which we are hoping to implement there.
It's essentially a SaaS business model that would be selling to companies, healthcare companies, payers, et cetera, that could then white label it and provide it to their consumers.
I don't want to hog up all the question time, so if another judge has a question, go ahead. Otherwise, I have one more.
Go ahead, Vivian.
Just when you mentioned something about location data versus the contact tracing approaches that others are using, can you just say a bit more about that?
Yeah, so
the problem, oh, sorry, go ahead, Ian.
Okay, I'll take the question. So the contact trace proximity data is very difficult to collect, and there's multiple studies showing that you need a large fraction of the population to actually participate, which is true. So implementing it at this point is not really feasible because you can't expect 70%, 80% of the population to participate in it right now. There's privacy concerns and there's a lot of things. What we are doing is we are keeping all user data on the phone, never sending it to servers, and that keeps the privacy intact. What we will do is we will track locations which are being marked as high-risk locations like supermarkets, etc. And users will have the option of contributing to this. And if they are willing to contribute to this, we'll update the probability distributions of these locations as whether they are more likely to infect or not. So this is how we will actually go ahead and do something with location tracking and not use proximity data.
So you say your customers are going to be companies or insurance companies, so they will actually, you see them using the data to assess the risk of a certain their employees or a certain population they're responsible for in some way.
Yeah, I think there's kind of two tiers to the value proposition for the B2B clients. One is for healthcare systems, payers, government entities. They can essentially be providing that as a service to their consumers. So, you know, if you're with Blue Cross Blue Shield, they're now saying, hey, here's an app you can use, right? So there's value add there. And the second piece is exactly what you're saying, is they then get that aggregated data view to be able to understand what that means for their business and their operations, whether that's a health system or a payer or a big company like Microsoft or Google or whatever that has big offices and big facilities they run.
And so do you think they would use that data to tell people not to come into the office or to influence their behavior in some way?
I think potentially, yeah. I mean, whether it's you know, kind of the passport type concept of allowing you to access their office or their service or whatever, or just influencing office layout, all the different things that people are having to think about right now to maintain social distancing and deal with the risk appropriately.
All right, we're gonna move on to the next team. Thank you guys, that was really good.
Hi, this is Gülay Özkan. We can go to the second slide.
All right, excellent. Give me one moment. Some of these rooms have a Zoom bomber, you might have noticed. So we're just managing that, no big deal. All right. Cool, go ahead.
Next slide, please. even before pandemic, productivity has been always a problem. Workplace interruptions cost US companies about 588 billion in lost production every year. 57% of business leaders believe they lose more than 6 hours per week due to disorganization. And poor communication can cost a large organization 62.4 million per year, according to research. Next, please. Due to the COVID-19 measures, now we have more distractions, more miscommunication and disorganization, a lot of rules to follow at workplace. How can we go back to workplace and be productive under these conditions? We need certainly help. Tia, next please. Tia is your artificial intelligence company to make your life easier at the workplace by helping you develop healthy habits and make you productive again. Next please. She chats with you through the chat platforms such as Slack, WhatsApp, Teams, and her conversations are personalized and based on your risk score, and she uses behavior science methods. Next, please. And as you see, our first prototype ready for the Slack channel. Basically, in her first conversation with you, she understands your basic data, and then if you want to proceed, then and she asks questions in 4 areas: mask, hygiene, social distancing, and commuting. And then when she finds out the problem, she uses behavior science methods to help you further. Next, please. And behind this technology, TIA is not a singular architecture, uses modular cloud services and use state of machine learning and NLP algorithms. Next, please. And the outcome, we create improved emotional health for employees, and companies will build reputation and then improve productivity, hopefully, which in turn would help recovery economy. Next, please. Our business model is a proven business model in the market. It's a B2B, and we will charge to companies. They will pay per employee with add-on 7 days trial and a month subscription. Next, please. Our go-to-market strategy is also simple. We will use chat platforms, then want to become white label app. Next, please. And since MIT Hackathon, we have done a great job, and we have applied for fundings, attended several hackathons, pivoted 3 times, run 7 user research in 7 languages, applied for Creative Distraction Lab of Oxford University, and here we are, and we will continue at this pace even after this hackathon. Next, please. We have done an amazing job this weekend and improved our working prototype. Also, we built our business model and details, and also we improved TIA as well. Next, please. Our team is a multinational team, and they have skills. Next, please. And what we are looking for, new talents to join us. This is not a temporary project. HR contacts from Fortune 500 and partner companies who work on productivity to partner. Thank you. And next, please. TIA is your AI company at your workplace. Thank you.
Excellent job. All right, we will start our 2 minutes of judge Q&A.
Zach, Paul, I have a question. Do you have any data or preliminary data, at least, that's showing how decreased productivity is for workers coming back to the office, specifically due to coronavirus and safety measures that they're taking because of it?
This is an excellent question. We have 2 different data sets. One data set, we have interviewed HR executives from global companies to understand what are their measures currently. What they do is they are just preparing PowerPoint slides and also a lot of documentation, a lot of warnings in the workplace. This is what they are focusing on right now. They are not right now. And one company said they do a questionnaire, but everybody says that their productivity is high, but they think that the people answer this way because they have fear of losing jobs. And second data, indeed, we have a lot of data which I can also share, that the anxiety among people is quite high about losing the job. And also the anxiety is already high. So this statistics comes from when they were at home. If they go to offices with all those warnings, and the behavior science basically say that there will be more anxiety. And we have a psychologist in our team.
And to do that, you're looking at some additional investment to get yourself an update.
So we have psychology in our team. So based on psychology and behavior science, we can say the anxiety will increase.
what are the ultimate outcomes that you're trying to measure?
In terms of measurement, of course, we would like to really humanize AI. This is our really kind of ultimate motivation. And we would like to get good feedback. What we want to measure is the user's feedback and how user is engaged with the TIA. This should be of course the one measurement. And another measurement, we measure the risk scores of both employer and the employees, and also the improvement on those risk scores also are one of our metrics.
Okay, so just to be clear, so there'll be a baseline score when somebody first signs up, and you'll measure against that baseline.
Yes, we keep of course measure that risk score, and that risk score is based on the credible sources. It's not just we are not just making it up, so it has a framework as well.
Awesome. I think that's all the time we have. Sorry. 2 minutes goes by really quickly. Okay, next up is Ulivity.
Can you hear me?
I can. All right. Jump on in.
Thank you. Hi, we're Ulivity, a digital waiting room. Next. Waiting rooms suck, and we know they've always been awful. Next. But in the era of COVID, they could be deadly. Next. What is worse, providers like myself worry that the fear of waiting rooms may keep our patients away. Next. At its essence, the problem is really how do we bring providers and patients together safely and efficiently? Waiting rooms are just an antiquated solution that now risks COVID spread and may deter patients from visiting clinics. Next. Our solution is simple, a virtual and digital waiting room that checks patients in from a distance to optimize social distancing. We're built for rapid adoption by being integration optional, and we are obsessed with an easy user experience, so no apps to download for patients. Next. So how does it work? Step 1, the patient receives a text with a check-in link before their appointment. Next. Step 2, the patient completes a web-based registration tool that alerts the clinic of their arrival. Next. Step 3, the clinic-facing software provides an intuitive workflow so staff only invite the patient inside when their room is ready. Next. Our workflow even allows patients to be screened for COVID before they enter clinic. Next. Since our first hack, we've made significant progress, including successful completion of a COVID-19 incubator. Thanks to MIT, we have been in discussion for collaboration with the VA's innovation ecosystem and are actively piloting at Kentucky's largest multi-specialty group, and my clinic moved over 100 patients safely in and out last week alone. Next. We are a diverse team of experts in business, medicine, and tech, comprised of our original group plus additional seasoned entrepreneurs whose previous companies are publicly traded or have successfully exited. Next. We intend to use our SaaS subscription business model where we believe clinics will pay a monthly fee to help return patients for face-to-face encounters. Next. As a case study, Doxy.me, a telehealth provider, added over 100,000 users in the last week of March alone, showing that clinics can be motivated to adopt new, easy-to-use technologies to see patients quickly. Next. Beyond that, we are excited about additional downstream digital tools, including improving co-payment processes. Next. The market opportunity is large, with almost 50,000 outpatient facilities in the US alone that have lost tens of billions of dollars in revenue due to cancellations from COVID. Next. Over this weekend, we have made significant progress with experts to vet our strategy for scaling, discussed adoption with potential users, and have discovered and vetted a parallel opportunity in the outpatient pharmacy space that may be more easily disrupted than the clinic space, thanks to our new team member, Anjali. Next. We have just now finished our MVP, anticipate piloting for the next 1 to 2 months, followed by an additional scaling and deployment. For example, we are onboarding our first outside clinic in Chicago next week. Next, we are Ulivity. We believe our technology can make a difference now and in the future. Please help us bring patients and providers together smartly and safely. Thank you.
Excellent job. I will now kick off the 2 minutes for Q&A.
Hi, Dr. Allred. I was a judge for your last time. It's great to see you, and you've made a lot of great progress, so fantastic job on that. I think one question that I even had last time that I think is still applicable to today is, how do you plan on selling into hospitals and getting that value prop across when they have lost so much money throughout the last quarter?
No, that's a great point, and that's actually something we spent a lot of time talking with mentors this weekend, which is how do you make it affordable? First of all, what is that price point? And one of the conclusions that we came up with is really not to outprice people. That users is very valuable, and the second part is to emphasize the integration option, so that if larger clinics are interested in integrating, that we can accommodate that as well. So for instance, with the VA, if that progresses, that will likely be what occurs. But for smaller clinics, who I think are actually very vulnerable right now, which has been a focus for us as well, is allowing them to not have to wait for weeks and have to spend tens of thousands of dollars to integrate. And so really we're trying to move this innovation at the speed that the pandemic requires.
Thank you.
I think this is really clever, really, really nice job, especially implemented so quickly. That's really impressive. Traditionally, as you know, adoption in any clinical environment usually takes weeks and months and years. So this is a great job. Wondering about two questions. One is how do you see the role of electronic health record companies in this space affecting you? And then the second is, while you have people in the waiting room, are there other thoughts about what you might be able to do with them while they're waiting?
Absolutely. Those are two great questions. So for the first one, with EMRs, it really depends on if they want us to play in their sandbox or not. We're hoping that we can get into those that are easier, but have enough users that we might have some leverage to be able to participate with EMRs. And in terms of what can you do with that time where they're waiting, I think that's a really exciting thing, including can you do actually patient education before the visit? So do you know that, for instance, I'm a dermatologist and someone's likely coming in for a skin screen. Can I talk to them about the ABCDEs of melanoma before that they come in? Or based on the coronavirus screen, if we think that they might be positive, can we give them information from the CDC ahead of time? And so we're trying to think about how can we use that time in a smart way.
Thanks.
Awesome, that's our 2 minutes.
Thank y'all.
Oh, there we go. All right, so next up is COVID Busters with our product COVInsight. Who's going to be representing COVID Busters?
I will be. Let's see.
Fantastic. All right. Feel free to jump in.
One other speaker too, who should be, I think her name is Brianna.
Hi.
Okay.
Oh, cool. We can hear you, Brianna.
Wonderful. So
awesome. Get started.
Clean, pre-processed, and centralized data is necessary for enabling accurate, predictive modeling for COVID-19 immunity. And Team COVID Busters is going to make this happen using COVInsight. Next slide, please. Sorry, next slide. Okay. We began during the first MIT hackathon as a collaboration between data scientists and biologists, working to develop a novel immunity test and data pipeline. Post-hacked, we curated a direct-to-consumer testing data set in collaboration with a group at Mass General Brigham, but we realized that there was no robust databases targeting COVID-19 immunity testing data. We set off to create this needed data set, following the model of a diverse, multi-parametric inclusivity, such as the UniProtein database. As researchers, it's incredibly frustrating. Oh, sorry, next slide. It's incredibly frustrating to go through hundreds of poorly curated publications and data sets on COVID-19 testing. Individual sources are often not comprehensive enough to run models on, and data sets are often incompatible between different data sets. There is no pipeline for the standardized collection of algorithm-friendly and up-to-date immunity testing data. Moreover, there's no protocol for translating this data into needed actionable insights around immunity prediction and community health. Next slide, please. Our solution is an integrated data collection pipeline and database. We've spoken with OneUp Health and will use their platform to partner with providers to record testing data and store anonymized data in our standardized database. This data is used to refine our machine learning model, share key data insights with providers, and identify untested individuals who likely have immunity and should be tested. Our key value proposition is providing access to a well-curated, up-to-date immunity testing database. Next slide.
Here we have designed our AI-based software solution to automatically optimize symptoms encoded as parameters to predict immunity. Next slide, please. Our intuitive dashboard interface explains the characteristics of our data. Next slide, please. With data visualization framework, we can make complex information easily digestible for biologists and healthcare professionals. These visual tools cater to the needs of busy scientists and officials who are often unable to sort through large data sets to find the information that they need. Our software finds critical information embedded in large datasets like a needle in a haystack. Here we can explicitly illustrate some heterogeneous data from our COVID dataset and show likelihood of test results based on patient's ethnicity, age, gender, and day since onset. The brighter the shade, the more confident the model is. The key value proposition of this solution is that it learns faster because it has an inbuilt online learning mechanism that learns and updates as data comes in versus existing systems that are static. Next slide, please.
For our go-to-market strategy, we'll start by partnering with county-level health providers and health departments, collect the initial data for model training and fine-tuning. The resulting analysis can allow providers and health departments to identify immune individuals, better serve vulnerable communities, and get crucial knowledge to prepare for a second wave. As we scale up, we'll partner with regional and national providers and health departments and develop a large machine learning optimized data set with high value for both research and both state, local, and national policymaking. Next slide, please. Why are we the best team to tackle this problem? Since Hackathon 1, we've gained several new members of machine learning and analytics skill sets for retaining biology expertise. Thank you, we're COVID Busters.
All right, thanks guys. I will start your 2 minutes of judged Q&A. Judges, feel free to unmute yourselves just in case.
I guess I'll ask a question. Who is your ideal customer right now? And then how are you going to be making revenue?
Yeah, I'd love to answer that question. Thank you. So our ideal customer would be either a healthcare provider, we'll probably start on the sort of county level and branch out to regional or national providers, or a health department, because they are going to be doing a lot of tests in the future. And we want to make sure that data is captured and used so that key insights can be gained. How we're going to make money. So we see our database as an open source platform that anyone can access. However, we'll be mining that database for key insights tailor-made for our clients. So we're effectively offering a software as a service where they pay us, we collect the data from them, and we provide them with key insights.
Unless other judges have a question, yeah, they can go ahead.
Well, I just was, maybe I missed it, but are you looking at geographically specific information, and could that information actually be helpful for individuals too in terms of understanding their own risk or changing their behavior?
Hi, I'd like to quickly drop in to answer that question. So there is a collaboration between geographic data, and geographic data is one of the core data points of our centralized curated database model. So if you could just skip 2 slides ahead, we could see that geographical data is given significant weightage in our model. So yeah, so these are the parameters that we're considering for the centralized database. And in terms of having geographical data, if a region has more than 80% population infected and recovered from the virus, then it's indicative of their having herd immunity, according to some preliminary studies. So we would definitely be using location data as one of our core parameters in the database curation process.
And sharing it with individuals. But that's not a use case, or it is? I guess that was the second part of my question.
I'm sorry, I did not get that.
I think we might be out of time. Never mind.
Oh, okay.
Thank you for your feedback.
Awesome. Next up is GMed Chain, who's going to be presenting from GMed Chain.
It's me.
Awesome. I will start your timer. Go ahead.
Okay, next. Hi, we're GMed Chain. We're a blockchain supply chain solution in healthcare system. Next. There are life risks due to the medical supply shortage and fraud. Today, the actual supply chain system is long and costly due to the lack of governance, transparency, and lack of integration between the partners in the chain. So, according to the WHO, $200 billion are sold on counterfeit pharma products globally every year. According to the UN, $2 trillion are wasted on procurement costs due to fraud and corruption. And imagine, though, nowadays, with the COVID situation, this is even worse. I mean, there are more than 4 million people infected with COVID-19, and the hospitals are struggling to get the right products at the right conditions at the right time. So next, that's why we're here. We're Image Chain. We're an open marketplace that integrate IoT, AI, and blockchain to deliver the people the technology they need with a trustable platform to buy their supplies. Next. Why we're different? Because we're customer-centric design. We are for non-technical people, and also we integrate the baseline protocol that let our customers to use public blockchain networks with the privacy of a private network. So that let us save 90% of the cost, and we're passing these savings to our customers. Next. So this is why we have a free model for our buyers, and we have a SaaS model for our suppliers. Next. So what have we done until now? We did 50 interviews. We signed up with 2 PPP vendors already. We built an IoT device, and we integrate that into our platform. So also we want to work with the public sector because we identified this use case is really helpful because they already need to publish this data in a public layer, immutable. We also want to scale up to vaccines and other products. Can you go next? We validate our idea already with vendors. Already with vendors. Next, please. We are a diverse team with a lot of background. And next, I want to show you a video of how it looks like. Okay. So this is the IoT part that we were building this weekend. So we're showing there how we build it. Yeah. This can track the temperature, the humidity, and all the stuff that we want to put into the chain. Yes. So let's stop wasting life and let's save people.
That's 3 minutes.
Okay, perfect.
Awesome. We will send it to the judges for 2 minutes of Q&A.
I would love to have a little explanation of what we just saw in the video.
So
I'll take that.
Yeah.
Hi, that was me you saw in the video. So basically what that is a smart pallet, which has like packages with RFID tags on them. And the smart pallet has a bunch of sensors in it. So for example, if you're transporting things like vaccines or things like medicines, you do want to know when during transportation, was your package subject to a lot of shocks? Was it subject to high temperatures or humidity, which exceeds the range of safe transportation? And our sensor package and our smart system actually records all this data and puts it in a payload and uploads it to the database. All this data is live, so every time a package leaves a location, so what you saw essentially are 2 locations. Let's say we're loading the package from a pallet to a truck. So we tag out at the pallet and then we go to the truck. We have a Bluetooth radio which kind of transmits all this data to a hub which is located either on the vehicle or the warehouse. And then you have like essentially constant monitoring of whatever supplies that you are transporting. And then of course, if the package is opened mid-route, you will know the supply chain will be immediately alerted of this in addition to all the data.
30 more seconds.
So you talked about, counterfeit medicines and corruption being a major problem, but then you're also talking about quality, kind of integrity of the transportation process. So how are you going to monitor items, for instance, that are medicines, that it's the same medicine that's produced, let's say, by Johnson & Johnson, and then when it reaches the the customer, it's the same medicine at that point. How are you going to have the access at both ends?
Yeah, that's what we build these IoT devices to let us track the authenticity of the product and let us track if they were stored at the right conditions with the right within the whole process. So we're relying on IoT devices for doing that, accomplishing that. Yeah.
May I have any addition? We're also using blockchain so that the real-time data cannot be manipulated.
Yeah, so the data that is going through the chain is immutable. No one can change that. So then we ensure that no one is incurring in fraud.
Awesome, thank you. That was really good, you guys. We're gonna have to move on to the next team. So who from Insight AI will be presenting for us today? Go ahead and unmute yourself if you are presenting from Insight AI.
Hey, can you guys hear me?
Yes, I can hear you.
Perfect.
All right, take it away.
Hi, everyone. My name is Cal, and I'm from Insight AI. Oh, can we go to the first slide? Okay. Hi, everyone. My name is Cal, and I'm from Insight AI. During the first hackathon, we identified that nurses and physicians spend 20% of their day on manual time-consuming inventory and supply management tasks. Think paperwork, searching for supplies, coordinating across units, and manual counts. As you can imagine, this takes away valuable time from what matters the most, direct patient care. Next, this issue got further exacerbated when the pandemic hit, and we started seeing inefficient distribution of PPE, supply hoarding by frontline workers, and many instances of shortages impacting hospitals' ability to provide care. Next, inefficient inventory management is a huge problem and can have a severe impact on patient safety and the quality of care. In a recent survey, 24% of clinicians indicated that a recalled product was used on a patient. 57% of physicians didn't have the products they needed during a procedure, and 18% of healthcare providers indicated that patients have been harmed for not having the right supplies at the right time. Next, in Beat the Pandemic 1, we had a vision of creating the most seamless and automated process to give back time to frontline healthcare workers. We ended up using object detection technology to give frontline workers real-time inventory visibility. Next, we've done a lot of work since the first hackathon. We rebranded to Insight AI, quantified the opportunity and value to hospitals, conducted an end-to-end product lifecycle mapping at a regional hospital, defined our system architecture and technology model in consultation with Amazon. We also got lucky and now have ongoing check-ins with mentors from BCGDV, Amazon AWS, and MassBio. Sometimes it's tough to imagine that we managed to do this in 6 weeks while working our full-time jobs. Next, in this journey, we learned that effective and efficient inventory management delivers value across 2 dimensions: operational efficiencies and savings between 2.5 to 5 million annually, but most importantly, it unlocks capacity for patient care. For a hospital with 125 beds, that's about 21,000 annual physician clinical hours and over 82,000 hours of nurse care time. Next, better inventory and supply management means better patient care and safety. In this hackathon, we split into 2 work streams, strategy and product development. For strategy, we conducted 8 deep dive interviews to better understand the problem, identified key product requirements from leadership teams to frontline staff, refined our go-to-market strategy, and launched our website. Next, for technology, we made progress on both hardware and software. Next, expanding our product detection SKUs to include hand sanitizers, bandages, and medical gauze, tripled the object detection distance, incorporated sensor fusion, and even built custom hardware. Next, play video. Through these developments, we were able to improve accuracy, increase inference confidence, and the speed of detection. As you can see, it was so fast we couldn't record a computer to do the count. Next. Ultimately, our goal is to deliver unprecedented speed and accuracy in inventory and supply management by combining computer vision, sensor fusion, and deep learning capabilities. Think Amazon Go for hospitals. Next. Yeah, next. Cool. We want to create a platform that enables what we call always have what you need when you need it technology. Next. So in this journey, we recently got accepted into the MIT iCorp Sparks program, which starts in 2 days. We got assigned a technology development advisor by Alberta and Vates to explore government funding for prototype development. And we also got introduced to digital-first innovation-focused hospitals to test our prototype and develop our platform through iterative feedback loops. Next, we're a nimble team of global strategy and award-winning design firms, AI development labs, and hospital operations. Next, thanks, and visit our website.
Awesome. Kicking it over to the judges for 2 minutes of Q&A.
I guess I'll go. So maybe I missed this, but it said 3 to 4 hours is spent per day doing inventory management. Do you have kind of any idea in terms of how much, like, are you looking at saving them time with inventory management? Are you looking at being able to save financially in terms of?
Totally.
Go ahead. Yeah, it sounds like you know.
Yeah. So it's gonna save on two fronts, right? So you'll get operational efficiencies and savings. So it reduces the overall inventory levels at hospitals because you have better accuracy and prediction and forecasting. There's going to be less instances of expired products, so rebuying those isn't going to happen again. And because the process is optimized, there's going to be possibly FTE reductions from the, call it, administrative side of things, right? So there's less folks going into inventory rooms doing counts and kind of all the manual paperwork associated with it and those processes that come with putting the manual information into systems. So that's your operational savings. And then, it also unlocks capacity. So if you think about the OR, by additional capacity and reduction of the inventory management time between procedures, hospitals can gain additional revenue. When you think about ICU units, you can increase the capacity and the amount of people that can kind of go through that.
I may have missed this, but most large hospitals that I've been associated with have pretty significant inventory management and supply chain management. So what is it that you're doing differently?
Totally. So when we did the surveys, some of the inventory management techniques or methodologies, use bins or like these par bins when you move it up or down. Also vending machines, or 78% of like hospitals in the US actually still incorporate manual counts in the inventory management process. So what we're doing differently is putting kind of these computer vision cameras. So as a nurse or a physician, when you go into the rooms, you actually just grab things and you don't have to scan or change the process in what you do. So it's a seamless and super fast process, right? As opposed to these alternative technologies that exist now that force a change in process, but also, they're a bit clunky is what we've heard as well.
So just object recognition, not barcodes or bar scanning or that?
We can incorporate that as well. So we've been thinking about that. So it's so right now we moved from object recognition and started including sensor fusion, so weight scales as well, to increase the confidence levels of what's been picked out.
Thank you.
So in a way, it's like one of those, the Amazon stores. The staff are just walking out and it's tracking.
Totally, yeah, pretty much. That's kind of what we're aiming for.
All right, guys, thank you so much. That was really great.
Thank you.
All right, next team, pneumotoroidal vents. Who's going to be presenting? Go ahead and unmute yourself.
So we are pneumotoroidal vents.
There we go. Okay.
Amidst making the world less vulnerable and more resilient, there are hundreds of patients suffering on hospital beds to breathe. Today, we present you a novel ventilator that caters life along the lines of fairly sharing the air. We present you the pneumotoroidal vent, the next generation ventilator, which is being designed with low cost components and low power components. Next slide. Next slide. So we want to cater the disaster and ad hoc center applications of ventilators and also try to give them the ventilator product with low power defibrillators and low power ECGs built on top of the ventilator and give them a full ICU which can be transmitted out from the hospital in these situations. We have designed our products 10 times at less cost, and we have gone through FDA application, fast track application through IP vendor. Next, please. So we seen a market demand for portable ventilators and portable ICU equipment pegged at $300 million right now, and it is expected to go beyond $2 billion. And we want to target this market with a complete modular solution at low cost, low power situations. Next slide. So this is a solution. We came up with this solution. Here we have a master pressure compressor with a unit pressure wall control system consisting of valves. And this toroidal vent bag will be fluctuating at PEEP cycles to actuate the ambu bag and give ventilation to the patient. Next slide. Next slide. Next slide. We maintain a solution to be accessible and less learning curve solution. So we made it ease of access. We always tend to make it a low on power, modular, and we achieved during this weekend, we have simulated a lot of situations on this ventilator and got the PEEP cycle. And we also seen that around for 1 million cycles, the device won't fail and it will be providing actuation. Next. So this is our timeline. We have been developing ventilator concept for past 3 months. We are trying to get our FDA approval, and we'll be out for a field trial. We have been contacting a lot of residential nurses and asking them what kind of difficulties they are facing with current ventilators and how we can help them with new concepts inside this ventilator. Next. Next. So this is our deliverable deadlines. We are trying to go through these deadlines and get a clinical trial out by October 1st. Next. So this is our diverse team, and we are trying to two new participants this week, and we have successfully simulated the conditions. Thank you.
Great job. 2 minutes for judge Q&A.
So could you explain exactly what the benefits of your ventilation system will be compared to the current ventilators?
Yeah, so current ventilator systems are only shareable between 2 patients. Now, because of that constraint, they are not able to share it between 8 to 10 patients. So our ventilator we will be able to share it between 8 to 10 patients at a lower cost of $800. Right now, one single ventilator, portable ventilator, is being charged at $2,000, and we have scaled it back to $800 with local manufacturers and suppliers. We are still seeing if this will be FDA compliant, but then also we are on fast track application track for FDA compliance check.
Can you walk through what the $20 million for seed is used for?
I didn't get you. Once again.
On the previous slide, it said a $20 million seed. I was just curious what that capital is used for.
So $20 million capital will be used for developing the designs top of this design, because this ventilator design will consume around $500,000 for us to build as a platform. We will be developing defibrillators, ECG machines, and other intensive care units at a low power setting, so that everything can be functioned into a single solution as a modular solution, so that patients who require those solutions, we can just plug and play type of device can be created for them.
You have 20 seconds left.
Yeah. Any more questions?
Who would you see as critical partners?
So right now we have been contacting people at Johnson & Johnson and BCG, and we have been asking them how we can proceed over this timeline. We have been consulting them, and we are also seeing market around disaster relief and NGOs to sell this solution upon the crisis. But during the crisis, we are still finalizing the business model, because now the partners cannot pay up the whole cost. We are pondering on the business model we can implement through the crisis situation.
Awesome. That is all the time we have. So we will move on to the next team, Clearcare, who will be presenting from Clearcare.
It's me, Leah.
Awesome. I hear you. And feel free to get started.
Okay, thank you. Next slide. So here's a quote. I would rather die of a heart attack at home right now than go to a hospital. So can you imagine what kind of fear might be behind a statement like this? Here at Clearcare, we're out to save lives by connecting people who are afraid to get the care that they need with the providers that can help them. Next slide. Next slide. Okay, so a third of Americans are not soliciting the care that they need, and that's costing the US hospitals over $50 billion a month. People aren't going to the doctor when they need to, not because the care isn't there, but because they're afraid. And as a result of this, care providers are losing business, not just hospital departments, but small businesses that provide care to people. There's a real need from both spaces and the people who need them. Here's the good news. Next slide. So there's a transparent, simple, and trustworthy way to increase business to care providers, decrease deaths due to fear, and improve protocols across the industry. Next slide. So this is Clearcare, our web and mobile app that connects people who are afraid to go to the doctor with the closest and safest facilities, enhances transparent patient safety protocols, and improves protocols through feedback to providers. Next slide. So care facilities can register their business information and current COVID protocols. And then second, patients can search for a provider by name and needs to find the protocols. And then they can contact them to schedule care. Most importantly, next slide, both parties provide feedback. And this is what makes Clearcare the most valuable. Next slide. So while other search engines with ratings exist for healthcare providers and insurance providers can provide long lists of care facilities in their network, none of them can offer what Clearcare can. First, honest, on-the-ground feedback from patients and centers who are scrambling for answers. And then second, an agile way of socializing and improving protocols. We believe we can sell access to patient and care facilities for feedback to these larger groups so that they can supplement their own patient provider systems and develop new and better protocols. So how will that help us? Okay, next slide. So from our current research, go back. So from our current research, we believe we can sell our services across providers for the whole industry, and we'll grow because we're getting referrals from these larger organizations. So next slide. To support this, our initial design for architecture is intended to be flexible, using serverless framework to create a Lambda for each flow. These can be used by website and other AWS products for future features such as Alexa, chatbot, or Lex-powered phone system. Next slide. So here's our progress from the first hackathon. We did an initial prototype, we did 16 qualitative interviews and developed a business plan. During this event, we talked to subject matter experts, put out a survey, polished our prototype, and then we redeveloped the business plan to better suit the needs of the market. Next slide. So as you can see, we've doubled our team from the original hackathon with more experience in software development, healthcare, and research. Next slide. So in summary, there's a transparent, simple, and trustworthy way to increase business, decrease deaths, and improve protocols. The answer is clear, it's Clearcare. This project means a lot to us, and we think this project will save thousands of lives. Thank you for your time.
Awesome job. 2 minutes of judge Q&A.
How do you scale past the fear of COVID-19?
So I'm not sure that we can scale past the fear of COVID-19, but what we can do is pull back the curtain on the protocols that are already being put into progress, right? And so we can socialize those between the small businesses in rural areas that are already trying to figure out what it is that we do, and give patients who are worried the ability to see what's on the other side before they go to the doctor.
Thank you.
Sure.
You mentioned that you that this offers more, that this could be enhanced beyond what insurance companies offer in terms of who's in their networks. But it seems like you also will need to have that information in order to direct people to the right systems, because those systems have to be able to provide in-network care for them. How do you think about that?
Yes, absolutely. So originally we thought we might just partner with these guys, but when we learned that the information that we were getting back as feedback to what the current protocols were and what the patients were giving feedback as, we thought that not only just partnering with them, we could also provide them something that they might want to pay for. Does that make sense?
I mean that the insurance companies might want to pay for, or the hospitals?
Yes, because the hospitals and insurance companies, the way that patients are getting to the doctor right now involves going through them sometimes. They don't always just Google, right? And so we thought it might be more important to work with the providers and the hospitals that are sending people out and to provide them something of service, right? The feedback that they're getting from those facilities. So one of the things we're looking for right now is a partner. Any other questions?
All right, I think that's all the time that we have.
Thank you.
Really good job. So next up is going to be Cobot, who will be presenting for Cobot.
That would be me.
Excellent.
Okay.
Yes, I can hear you. I will start your timer. Go right ahead.
Okay, next slide. Next slide, please. Okay, on average, most countries have 1 doctor per 300 people, which is the recommended ratio established by the WHO. But in Peru, imagine that same doctor has to care for as many as 3 times as many people. So how does these numbers reflect in reality? Next slide, please. Let's meet Maria, a young mother living in the Peruvian Andes. Her daughter suffers from malnutrition, and they have to walk through 3 to 4 hours to the closest outpost because Maria has some questions about her treatment. And to make things worse, she doesn't know if the doctor will be available when she gets there. Next slide, please. Her doctor, Diego, despite his best efforts, cannot keep up with the burden of work. All of this was happening before the pandemic. Next slide, please. And you can imagine now how much worse it is. Next slide, please. That's why we are presenting Cobot. Cobot is a digital tool, next slide, please, for connecting rural patients with doctors by helping them identify high-risk patients, empowering patient self-care, and optimizing their time together in appointments and visits. Next slide, please. Using already available data from diverse sources, we can provide the doctor with a prioritized patient list, which includes their location and a brief individual health profile of each of them. Next slide, please. Using already, on the other side, patients now have a 24/7 chatbot through SMS voice calls to ask for basic info, receive notifications on appointments, and when deemed necessary, escalate the situation to the doctor, giving the healthcare practitioners some extra hands to check on their patients at any time. Next slide, please. And to streamline the attention process, doctors can schedule and coordinate with their patients, appointments and visits. And at a quick glance, they can have all the information necessary at hand. Next slide, please. So with Cobot, Diego is now able to better manage his workload and maintain a well-being and the health of his community. Next slide, please. The opportunity for impact is here. We're planning a pilot in a community of 3,000 people here in Peru. And in the whole country, we could reach 6 million people living in rural areas. And on a scale of Latin America, it's around 60 million people. Next slide, please. We expect to kickstarting this project to cost around $4,000, including human resources and technology. And to keep it sustainable, we plan to sell it as a software as a service model, aiming to sell it for $100 as an annual subscription. Next slide, please. Right now, we are finishing the proposed concept and have already started working a prototype to test. With Carlos, one of our team members, a healthcare expert, we're planning to start testing it next month, as I said, in a rural community in Ayacucho he's currently working with. Along that line, our team doctor, Diego, is starting his rural health service next month. So he and his colleagues will be key ambassadors and first-hand users of our system also. Next slide, please. And our team is hands down the best for the job. So far, we've been one of the winners of the MIT COVID Challenge and also won a Tech Startup Challenge in first place. We have interviewed around 20 healthcare practitioners working in rural outposts and gotten mentorship from local specialists in healthcare. Join us in the challenge of helping rural healthcare too long ignored in our country. Thank you.
Awesome job. I will allow the judges to jump in for 2 minutes of Q&A.
How much does this rely on the rural communities having smartphone access?
Not so much, because we plan the chatbot service to be via SMS and voice calls, so the rudimentary phone is enough, and we know that the coverage is more than 90%. in the community we're starting.
Okay, so there's no bandwidth restrictions or anything like that that play into it.
Excuse me?
There's no bandwidth restrictions or anything like that play into it.
For the chatbot, no, it would rely on cell phone communication, not internet access.
Okay, thank you.
How do you expect to train the chatbot? What data sets do you have to train?
Okay.
Yeah, so hello. So it will be basic questions, like the first kind of bot, like the most basic one, for example, like trying to answer some questions as triage, for example. But the next step is, of course, to try to include this NLP much more powerful or efficient way to try to, for example, answer questions about treatments that for a specific diagnosis that a doctor has already set up. So that's a basic idea. But to train the chatbot, we'll have the expertise of the doctors we have in the team. So that's basically it.
And starting with a pilot also, right? So
yeah.
In order to scale this initiative, who would you see, who do you plan to partner with?
We are looking to partner with, right now we're talking with local healthcare networks in our rural communities in order to start testing, but we need, especially for the cost of the chatbots on the database, we've seen many businesses that manage that type of industry. Maybe David can expand a bit on that also.
Yeah, well, key partners are basically the regional chiefs, because that matter, they are going to be the ones that could be the ambassadors of this idea and try to educate their citizens, or the chiefs of the medical outputs, to use the chatbot, this application, and also the platform of code.
All right, that is all the time that we have. Thank you guys. That was really good. All right, up next we have Deploy Smart, and just to orient everybody, this is our third from the end. So we have 3 more, including this one. Who will be presenting from Deploy Smart?
That would be me. Am I coming through clearly?
Yeah, you're perfectly clear.
Great.
All right, kick it off.
Next. Meet Nurse Faye. When the COVID pandemic hit, she was eager to help. Unfortunately, in April, she was let go from her job despite 42 years of valuable nursing experience. How is it that such a disparity exists? As of today, there are 1.75 million cases of COVID-19 in the US, and more than 60% of states indicate they need emergency healthcare support. And yet, 1.4 million healthcare workers just like Faye lost their jobs in April. Next slide. US hospitals and health systems are predicted to take a $200 billion hit by June. Since labor costs accounts for a large part of expenses, hospitals have to let people like Faye go. With fewer providers to care for sicker patients, healthcare workers are unfortunately demonstrating high rates of burnout. Burnout in turn has been associated with increased medical errors and worse patient outcomes. Next. This is where our company, Deploy Smart, comes in, redeploying staff where they are needed the most to prevent more healthcare workers like Faye from job loss by sending them to other hospitals that are understaffed. We provide a predictive analytics decision-making tool for hospital providers to decide whether they need to source staffing or if they can outsource their own staffing to other hospitals within their system that are in need. Next. As a clinician manager myself, I can attest that shift scheduling is a major pain point that takes hours out of my work week. With Deploy Smart, I'm quickly able to log on and at a glance determine where staffing surpluses and deficits are. Therefore, I can reallocate healthcare workers to units or hospitals where they are needed. Next. So how does Deploy Smart work? As you can see, a healthcare worker will receive a push notification to their device if they are redeployed to another hospital within their system based on their indicated preferences. It is simple, intuitive, and user-friendly. Next, let me showcase the prototype. Our machine learning algorithm works by identifying hospitals within the same system that need additional staffing. We deploy staff by calculating a utility score, which is based on specialty, shift preference, language proficiency, and individual profiles. As you can see, Chicago Hospital needs 3 providers. With Deploy Smart, we quickly identify providers in their system and send them where they are needed. Next, we believe that Deploy Smart offers a comprehensive staffing solution for COVID-19 and beyond, and is superior in comparison to other shift scheduling applications. Next, we determined we'll likely use a tiered pricing model, and based on our calculations, Deploy Smart could potentially equate to thousands of dollars of salary savings. Next, since the last hackathon, we refocused to working within a single hospital system due to licensing and credentialing concerns between systems. We conducted market research and received incredibly valuable feedback from end users to inform our prototype. Looking to the future, as we move to the new normal, we know that Deploy Smart is also scalable for a wide range of other industries, including gig economies. Next, additional progress from the last hackathon include ML algorithm development and creation of an app prototype. Next, I am Monica Nandwani. We are Deploy Smart. We streamline shifts, simplify staffing, and save lives. Next. Thank you to all of our mentors and to all of you. Thank you.
Great work, Monica. I will pass it over to the judges for Q&A.
Nice work. Can I ask you about how hard it is to scale this across different systems? Sort of more of an implementation question.
Yeah, so that's a great question, actually. So initially when we had started, we thought doing it across systems, but then recognized that licensure and credentialing, particularly for providers across states, can be problematic. And so we want to focus within hospital systems first to kind of get over that challenge, but we hope to partner with different systems to see how we can make it potentially more seamless. So for example, for nursing licenses, there's the compact states, and within compact states, if you're licensed in one state, you can practice in 24 states. So that makes it a little easier depending on the type of clinician.
Thank you.
You're welcome.
And so how do you see kind of managing the quality and the, of the individuals that you move around, since the one hospital may not have experience working with someone that perhaps has a, an employment issue elsewhere?
Yeah, so that's a great question. So as the next step, actually, we were talking about potentially doing like a quick onboarding guide for each individual areas to help onboard those individuals. And that's the other reason that we're kind of focusing on within healthcare systems, because at least those providers have been vetted within their own healthcare systems.
So you would actually have information about each person in your system before they were deployed?
Exactly, yes. Because with, when providers start at any hospital, they have to go through a very intensive credentialing process to verify all of their licensures. And so if we are deploying people within the same healthcare system, we at least already have that information. Additionally, we are also asking individuals to upload their individual profiles so we have more information about them. And on the back end, we can validate that in the future.
This is less of a question, more of just a comment, but even within health systems, a lot of them have different EHRs within different hospitals, and that might be a difficult thing for physicians to adopt to just kind of keep that in mind, so that if somebody goes to a different system, they actually know which EHR they're going to be using.
Yes, that's a really good point. Thank you.
All right, that is all the time we have. Thank you so much. Next up, we have Connect MD. Feel free to unmute yourself if you are the presenter. Who will be presenting?
This is Ala. Can you hear me clear?
Yep, hear you perfectly.
Great.
All right, feel free to write in.
Okay, can I have slides up, please? Hello, everyone. My name is Ala Najar, and I am a psychiatry resident in New York, and I worked in the last 2 months at the Emotional Support Center in my hospital, which inspired my team Connect MD to build a virtual support group for physicians like me to prevent burnout during the second wave of COVID. Next. As you all may know, burnout among physicians is a pre-existing problem, affecting almost half of the workforce in the US, and given the fact of COVID happening, it got even worse. Next. I've been studying this problem in the last 3 years, and I decided to identify a target of physician in training as a primary people to help. The three problems that physicians like me face is 1, poor access to mental health during training, 2, stigma to mental health due to licensing issue, 3, lack of time to seek help because of long work hours. 3, go next, sorry. So why is that target market is important? As you see here, physicians in training is a huge underserved population, and our product can extend to different career stages, as you can see here. Next. And this is the market worldwide. How big is the healthcare workforce that we can expand to? Next. So what's our solution? It's a mobile app that offers 1 virtual support services among physicians, confidential peer network that have private space and access to mental health resources that match and tailored need for physicians' specific interest. Next. So before I go over the demo, I want to tell you, oh, we're going to do it again. Laura is a hypothetical friend that I made. She is a 35 years old surgeon resident, decided to download our app because she heard it's awesome. And let's see what Laura will get when she downloads that to deal with her parenting problem. Oh, here you go. So she will register herself and she will have an avatar ID. She will have a personalized environment, identify her specific challenges, and then choose the group that fit her needs at the time that she finds perfect. And voila, she's there. 45-minute sessions a week for the time that fits her need. It can expand from 2 to 3 weeks into 8 weeks. Next. What we did post hackathon, tons of things. Let's highlight. We had new members. We are here presenting. We partnered with Physician Hotline founder. We had identified 1 academic hospital to start at. We recruited 2 mental health providers to give our first group. And we have identified 2 potential development companies willing to take that further. Yay, next. So what's our business model? So the 3 primary revenues that we are targeting: hospital-based subscription, crowdfunding, and revenue from in-app purchases. Next. The pricing plan is going to depend on how big is the hospital subscription will be. And we'll give them 3-month free trial to see how that's working and to try the groups. We also will have month-to-month individual plan for physician in training who with very minimal monthly fee because of the fact that resident in training have an underpaid function. Next. So we're looking for investors like you, and we want your support to reach our target goal for achieve the following steps. And we actually want to really build a good, strong infrastructure to achieve our goal. So what's now? Next. We will build minimum
I'm
viable
gonna
product.
have to stop you there. You're pretty well over time.
Okay, no, you can go to the team slide. Thank you so much, guys.
Okay. All right, we will jump to Q&A from the judges.
Do you mind keep the slide before the team? Yep, on, so it can help with everything. Yep, thank you.
Sure.
The current way that burned out medical students or providers are like finding support systems. The only one that I can think of is like a Reddit community, but you probably have more knowledge about that than me. How are they currently finding support systems right now?
It's very dependent from organization to another. It's what they serve. So poor, or not poor, community hospital that have residents that have low incomes, they actually offer them whatever the insurance is covering. Like big academic places have more well-structured well-being programs. Like my hospital is considered a middle-sized program, so we do have an access to mental health. But my friends in the community hospitals that I talk to, they don't actually have that. So they have to go through their insurance, try to find providers by the word of mouth, and it's very sad that there's sometimes you need to know that in a good way, because you need a like you worry about your license and you need to find someone that you can trust with this information.
Thank you.
My understanding though, and as you mentioned, that if you seek any mental health help as a physician, you need to report that. So I don't understand how this gets around that issue.
Well, that's correct. You don't have to report. The reporting is vary from a state to another, which is
that was in 37 states. It's pretty strict.
But you don't. There's a wide spectrum of mental health disorder that I treat. And I think what we are getting around it is we're offering skills group to start with. We're giving them something similar to the DBT, the stress tolerance skills group, as teaching them. So they didn't have to disclose anything. They're getting the resources. And then after that, if they want to have the one-on-one telepsychiatry services, we're giving them access to that service. So you don't have to report a mental illness unless it's intervened with your work. Like, let's say I have ADHD, I don't report that, but I do get treatment for that.
Thank you.
You're welcome.
All right, thank you so much. We are on to our final presentation of the afternoon, Vistan Health. Who will be presenting?
I am.
Awesome. Feel free to jump right in.
Excellent, my slide. Hi everyone, my name is Nina Keshavarzi and I'm a founder and CEO of Vistan Health. I have introduced to healthcare when my mom passed away from cancer and have more than 10 years of experience in healthcare industry. Our team mission is to facilitate triage of patients with chronic disease and help them get the right care and resources in a timely manner, anytime, anywhere. We are studying with cancer, second leading cause of death in USA, and targeting lung and breast, which have the most new cases, regular appointments, and death rate. Over this weekend, we have received great feedback from amazing advisors and talked to more than 150 healthcare leaders and patients. We evolved our business model and have developed the second version of our AI voice-driven web and mobile application. We have built a diverse medical and technical team, supportive advisors from top hospitals, Harvard, BMC, Partners Healthcare, and we also have strategic technical and medical partners that believe in our mission. We got also accepted to the Summer Accelerator. Next. Patients with lung and breast cancer require several checkups during a month, and there is a huge risk to get COVID-19. Let's take a look at the current situation. Many of our patient recurring appointments have been canceled and have long waiting time. Indeed, hospitals are at 25% of their capacity for outpatient visits, and there is a huge backlog. Also, more than 2 million cancer operations is projected to be canceled or postponed globally. This has increased the risk of transmission within these patients and worsened their health. Next. And the cost to health system is huge. It is projected to be more than 170 billion per year for cancer, majority of them coming from lung and breast. Next. We came up with novel solutions that can add values to both patient and healthcare providers. Vistan is AI character and our user interface is designed for patients that might not want to type anything. We take into consideration their conditions, humanize our AI, and developing voice-driven platform. Now, Sarah can use her voice-driven to get required care and resources anytime, anywhere. Next. There is a huge market for Vistan team to make an impact and improve patient care during and after this pandemic. We are targeting patients and with projected market share of 120 million. Next. We have supportive medical advisors that are all affiliated with top hospitals and Brigham. It is based on subscription model and it will be free to physicians and patients. Next. We are the perfect team to do this, and the timing is right. We are a diverse team from all over the world for both technical and medical expertise. And I believe and confident that we can accelerate our growth. Meanwhile, we have supportive medical and technical advisors that help us during this journey. Next, we have accelerating our growth and aim to pilot our product in July. We will launch the first version of our product in November. There is a huge problem, especially during this pandemic. We have innovative solutions that can add values to everyone, and I believe we can make a huge impact to patients during this time. So if you would like to support us with our mission to make a big impact and help us in our journey, consider Vistan Health. Thank you.
Great job. 2 minutes for Q&A.
Great presentation. Can you talk a little bit about the degree to which this is integrated with the healthcare system versus with the insurance company?
Absolutely. At the beginning, we are targeting, because we have supportive advisor, at the beginning, we are targeting hospitals, and it will be integrated to their system. We get a chance to talk to AWS and also One Up Health and one other partner, and we are willing to integrate and get their help, specifically for getting electronic health records integration.
Thank you.
Thank you.
Okay, I can ask you one more question about medications. Have you thought much about the degree to which this would be used to guide patients in, you talked about managing cancer patients and others with chronic diseases, and so much of their care is really about medication management. Can you say anything?
Absolutely. So our solutions also from the healthcare provider, they can track medications of all these patients, what they have used so far, and also they can see the impact on each patient gradually. So based on that, they can also provide automated interventions for each patient and also the impact. Thank you.
We've got about 25 seconds left if anybody has another question.
How about costs of care? Or do you plan to include anything about the cost of care for patients? What their out-of-pocket spends are?
So it will be free at the beginning for the patients, but our revenue stream.
No, not for your business, but your business, what they might need to pay for care when they go to get seen.
Absolutely. I think that's something that also we can take it into consideration.
Thanks.
Yeah.
Awesome. I think that's all the time we have. Thank you. All right, guys, you did it. This was an incredible weekend. I'm so proud of all of you. So just to kind of quickly recap, you came on Friday night, you had existing teams, but a lot of you had never done a hackathon or a challenge like this before. Some of you, this was your very first time. Some of you, you're a total pro and a veteran and you've done these before, but you were willing to jump in and help these existing teams. Rather than form brand new teams and start from scratch, you were able to help these teams that have been working on this for a month or 6 weeks to push forward and to get even closer to getting out into the world to try and help in this crisis. So I just want to commend all of you for taking so much time. This was a lot of work. Like the amount of work that I got to see from the beginning of the weekend to now is just massive. And the progress between all of the different pitches and pulse checks and practices and conversations has been tangible. It's been very, very, very impressive. And I'm very, very proud of all of you. And I want to thank all of our judges for this incredible feedback and asking really, really good questions. They have a very tough job right now. So we're going to head to judge deliberations. And that should last probably about the next half hour or so. The awards ceremony will be at 4 p.m. Eastern. This is a Zoom link, but we're going to send it out over Slack as well. I think you guys should all feel very proud of yourselves. And this community, as you guys know, has continued on from the first challenge till now. It's going to continue on from here. So we will hear who the 3 winners are, but regardless, there are resources available to you through this community, through the MIT ecosystem, and through the team. So what I'm really excited about is getting POCs off the ground and getting partnerships down between our partners and you guys. So that's what I'm really excited about. Whether you're in the top 3 or not, I want you to think about how we can continue to work from here, how you can keep pushing forward, and which partners in our ecosystem might make a lot of sense for you to talk to after this. So there's always a tomorrow, there's always more to do from here, and we're here to support you as you go. So we will break from here now. The judges, I'll send you another link and then we'll go do our judge deliberation thing. But we will see you guys again at 4 and we'll be available on Slack if anybody needs anything. Thank you guys so much. You should be really proud of yourselves.
Thank you all. Great job.
Good job, everybody.
Good job, everyone.
Yeah, great work, everyone.
Thank you.
All right, and judges, I will see you in the Slack group.